good morning, everyone, and hello. I'm sure we have a few people who are in the afternoon at this point. Welcome to the AHESS session for today. We'll be mainly focusing on emergency medicine care. So with us, we have three panelists. We have Dr. Annet Alenyo, who is a Ugandan emergency physician. She's also a technical advisor in the Department of Emergency Medicine at the Ministry of Health Uganda and the SEED Global Health. She is the current president of the African Federation for Emergency Medicine and the outgoing president of the Emergency Care Society of Uganda. Her interests lie between disaster medicine and critical care. She is a strong advocate for children and women's rights and a strong believer in Nelson Mandela's words, "It always seems impossible until it is done." So Dr. Annet, maybe you can say hi so that people can see your face.
Hi, Lilian. Hi, people.
Yes, so that's Dr. Annet Alenyo. Then we also have with us Dr. Adebisi Adeyeye. So she's a final year medical student at the University of Lagos, the College of Medicine, an aspiring emergency medicine physician and disaster medicine specialist, an expert volunteer and volunteer management trainer. Then due to the paucity of resources, information, and support experienced by emergency medicine bound medical students in Nigeria, she's founded the Emergency Medicine Interest Group, which is a student organization that seeks to provide a community as well as support, information, and resources to medical students who are seeking to pursue further training in the field of emergency medicine. In her spare time, she enjoys creating content on personal as well as professional development for medical students. So Dr. Adebisi, maybe say hi.
Hi, good morning, everyone.
Yes, so that's Dr. Adebisi. Then our third and final panelist is Dr. Benjamin Wachira. He's an assistant professor of emergency medicine at the Aga Khan University Hospital, Nairobi, the founding director of Emergency Medicine Kenya Foundation. This is an organization dedicated to ensuring timely, accessible, and quality life-saving emergency care in Kenya. He is also the immediate past president of the African Federation for Emergency Medicine, an international association aimed at supporting emergency care development across Africa. Dr. Wachira has also published several journal articles that reflect his research interest in the developing emergency care in Kenya, and also serves as an associate editor for the African Journal of Emergency Medicine. So Dr. Wachira, say hi.
Good morning, Lilian, and good morning, everyone. Welcome to the session.
Yes, so we'll start the session with a keynote address by Dr. Annet. So Dr. Annet, maybe you may proceed.
Thank you, Lilian. Thank you, everyone. And I am very excited to be here. We didn't have this when I was a medical student, so it's very exciting to see what time and time and development and efforts have done to the landscape of emergency medicine in Africa. So before the session started, the panelists, Lilian and the rest of the panelists and I were discussing about, what emergency care exactly means in Africa, and how there is this misconception that you need to have an advanced course or an MEd for you to be a certified emergency care provider. So before we come back to that discussion later, let's just have a look at a multidisciplinary approach towards emergency medicine in Africa. So if you do a simple Google search, probably one of the first hits you get is, or the top hits you get, is this very nice definition about what's happening in modern healthcare. And essentially it says modern healthcare is delivered by a multidisciplinary, distributed healthcare teams who rely on effective teamwork and communication to ensure effective and safe patient care. Think about all the aspects that this definition has covered, right? So it has to be a multidisciplinary, it has to be well-distributed, and these teams have to rely on effective teamwork and communication, so they provide effective and safe patient care. The question this morning or afternoon, for those of you in the afternoon, is, can Africa deliver this? So let's look at Africa. I'll just go back in time. Let's look at Africa before 2008, before a number of people met in Cape Town and decided to form an organization called the African Federation for Emergency Medicine that has provided a strong foundation for many countries and individuals across the continent and beyond. So before 2008, when there was some, continental formal recognition of a group of practitioners who have been doing something, well, emergency care was being done. We had emergencies presenting to hospitals, clinics, and health posts all over Africa. And patients were managed with emergencies. They got better, they were discharged. Of course, some didn't get better and they died, but there was some semblance of emergency care being provided to patients. So emergency medicine as a specialty, and I'll just unpack this quickly. Emergency medicine is it's a medical specialty that doctors do. You can compare it to pediatrics, and MMed in pediatrics, and MMed in surgery, etc. So emergency medicine on its own is just one small component of an entire continuum of emergency care, which encompasses so many other people, not just the doctor. So I'll just give you an example of what would happen ideally. So let's take an example of a small, say, 5-year-old child who gets an accident in rural Uganda. We have lots of boda cyclists. I'm sure that pandemic has spread in other parts of Africa. Really danger on 2 wheels, a lot of accidents from boda cyclists. So let's say a 5-year-old in a rural part of Uganda is hit and in a hit and run accident by a boda cyclist. So this is what I would expect, or what I would love to see happening. So there's on-scene care, a bystander wherever this has happened, be it in a small town, in a trading center. A bystander is able to immediately activate a system. They get a phone call and they are able to speak to someone who is part of a system that is going to respond to this incident that has happened. This person who is called a dispatcher, will give instructions to the bystander. An example, if a child is bleeding and you have gloves and something to keep you safe, you can apply pressure on the bleeding part. Keep calm, keep the child calm, speak to the child and encourage them. That's a simple instruction. At the same time, the dispatcher will send an initial provider. Many of us have community health extension workers who can be one of these, tier 1 or lay responders that will then be sent to assist the bystander to respond and to support the child. When the provider comes, and if there is need for advanced care, say he discovers, this is actually a polytrauma, I need to take this child to a facility. The dispatcher will then be able to send a professional team with an ambulance while the on-scene care is being managed. They'll send a professional team with an ambulance who will then transport this child from the scene of the incident on an ambulance that is not just a vehicle, but that is able to provide care during transportation. When this child arrives and is taken by the ambulance care team, say the emergency medical technicians or paramedics, depending on the country you're in, they have to hand over this child to a provider in a facility. Depending on the provider and the facility, this can be anything from a nurse to a doctor, to a senior doctor, a senior consultant, etc. A proper structured handover of all the events that have happened before and the concerns and the patient's clinical status is done to a provider. That provider receives the patient in an emergency department in a facility or a small emergency unit or an emergency care area if it's a small clinic and you say have a 1-bed area that is dedicated to managing such emergencies, for managing emergencies. This child is then going to be in the facility and is going to be managed by a number of people. There will be a nurse, there will be a doctor to manage in the emergency department. There will also be other auxiliary staff that are not necessarily medical. There might be a porter to wheel the child to x-rays. There might be a cleaner to make sure the area where the child is being managed is kept clean and safe. This child is then taken, for example, to imaging. A radiologist or a radiographer does the scans, whatever has been required. These are then brought back, read by the emergency care team, the emergency physician or doctor in the emergency department, who then consults. I will give an example of a neurosurgeon. A neurosurgeon comes, makes a decision to do an immediate decompression. The child is taken to theater. In theater, there's another team. There's a theater nurse, there's the anesthesiologist, there's a theater porter, there's a whole other team that is in theater that is going to manage this child. There's the lab guy who probably has to send down units of blood. There's a pharmacist who has to think of antibiotics or other prophylaxis care to send down to the child. Post-op, this child will need to be in an ICU. The ICU team, again, one huge team of a totally different kind, specialists, intensivists, specialist emergency care, nursing, specialist nursing, ICU teams, etc., etc. Depends on the ICU and the facility you're in. So if we look at the child, so that's an ideal situation. And I know some of you will probably be thinking, this doesn't happen in my setting and probably won't. But some small bits of this happen, okay? What I've described to you is an entire well thought out, complete continuum. But the problem with our setting is a lot of this is not in place because many times we're thinking in silos. Think of this child again. How many people did this child interact with during the continuum of their care? And I didn't even continue into rehabilitation and social worker up to discharge. So if you think of all of that, how many people were involved? How many providers? How many categories of providers? So what is a multidisciplinary approach to healthcare? So it's essentially a model that brings together people from, different providers, physicians, nurses, social workers, physiotherapists, and all types of specialists to provide healthcare that reduces potential errors in patient care and improves patient outcomes. Do you have this in your facility? Think about it. So the whole concept of multidisciplinary care is working as a team. You do have all your different specialists, but if you work in silos, if you work independently and only think of what contribution you give without thinking how it impacts the other specialist or the downstream journey of this patient, then you're doing a disservice to both yourself and the patient. So teams, a multidisciplinary team essentially enables members to independently treat the various issues a patient may have, focusing on the issues which they specialize, but well cognizant of what happens and the role of others. So the activities of this team are brought together using a care plan. And this plan helps to coordinate the services of this team and gets the team working together, all right, towards a specific goal. So if you don't define a specific goal and you don't coordinate a team to achieve that goal, that's it. You're going to have a fractured and dismantled system that is not going to be effective to patient care. You're going to get very frustrated because each person is not thinking of their role, or someone is trying to do what they should do and what another person should do and not doing it well. So the beauty about emergency medicine is it's cross-cutting, all right? We know everybody in a hospital because we interact with everybody in a hospital. One of my consultants during my training told me an emergency physician should be able to do everyone's role, from the cleaner to a resuscitation team leader. And in knowing that, it helps you, if there is a gap, to be able to step in and ensure that the care that is being provided is seamless. So if you think about Africa, there's probably challenges here, and I'll come down to the challenges later. How many specialists or opportunities for specialization do we have in Africa? Lilian, before the session started, was talking about how there's no emergency medicine program in Kenya, no MED, but Kenya has a society that has recently hosted a mind-blowing conference, the first virtual conference. They're doing a lot of great work. Do they have an MED program? No. Can they still provide emergency care? Yes. So multidisciplinary approach is not a new thing. It's not a myth. It's not something we don't know. If you look at this slide, it shows you so many different studies that have been done on different aspects of multidisciplinary approaches to healthcare. Looking at teamwork, looking at communication, and all different specialists, not just emergency care. So I just picked this slide from a study done by OBGYs, and it looks at, different facilitators and barriers to providing a sort of comprehensive quality care. And you see that everything seems to be connected, not disjointed. So if you have a multidisciplinary team, I've shown you the continuum of care. If you remember the child and the journey of that child from when they had an accident to when they're being discharged, all right? So to have a multidisciplinary team that can provide that quality of care safely is very beneficial. So as we think in our facilities, even as we train, I hope you can encourage some of your classmates to do the other specialists that are complementary to yours, and this goes for the students. So multidisciplinary teams convey many, many benefits, both to the patients, to the health professionals, to families, and to the community, essentially. You have improved health outcomes, enhanced satisfaction of patients, more efficient use of resources, and I put that in bold. We often complain about resources, but sometimes in our settings, you find that we actually become very wasteful despite our few resources. If we have a multidisciplinary approach, we will definitely have a more efficient use of resources. We'll also have enhanced job satisfaction for team members, for our health workers, no burnout. If I have to do everything, 5 things along the continuum, then I'm definitely going to get burnt out. But if I cannot be allowed to focus on what I'm doing and as part of an overall bigger picture, definitely better for everyone. So what can be the barriers to providing a multidisciplinary approach? Communication, often the first thing to break down when there is any type of problem in the house, be it at home, be it a major incident, be it in a hospital. Communication. It is the core for a team. It's a core skill for teams to work well together. The other issue is separate documentation. If a nurse comes, writes her own form, takes it away. The doctor comes, writes his own form, takes it away. The physiotherapist comes, does his assessment, makes his notes, goes away. A nutritionist comes, makes his assessment, goes. The admitting team comes, makes complete chaos. Nobody knows who is doing. You have one unified documentation. All the documentation is together. Excellent. Everyone is updated. If they're not, all they need to do is read through what everybody else has written. Poor working relationships. We know this. I don't know any emergency physician who has not had some sort of incident with an admitting team. The good thing is these things often, clear very fast. And remember to have good working relationships. Respect yourself. Be respectful and appreciate others' roles. if you have a healthy working relationship, people will respond to you because you respond to them well. People will come when you need them. You know, if you need a surgeon, they will know there's something wrong. They will come immediately you need them. The other barrier will be lack of awareness and appreciation of the roles and responsibilities of others. So emergency medicine in its establishment in many countries often struggles initially, and even in Uganda, we are still going through this process. In an emergency medicine naive setting, people will often not understand the role of an emergency physician. I've been called a physician, I've been called a trauma doctor, I've been called lots of things, oftentimes things which I am not. And many times it takes a lot of advocacy, it takes a lot of proving yourself, literally, for people to understand what the specialty is about, how it fits in the health system, what is its role, what is its contribution to the overall improvement of healthcare in the system and in the country. So everyday advocacy should never end. If it means starting a WhatsApp group, start it. Post information, engage, make sure you have key people on your WhatsApp group. In the Uganda Emergency Care Society, we have a very strong advocacy group. We have senior ministry officials, we have NGOs, we have students, we have MED residents, we have people working in other ministries, other aspects in insurance. It's a big advocacy drive. And when you discuss issues, everyone responds from their perspective, and having all those different inputs, people get to understand what their role is in all of this. Of course, the next issue is going to be limited time and resources. Please, my friends, be resourceful. Having no resources should not limit you. Think of different ways. How can I do this easier? I don't have this, but I have this. So if I use this in XYZ way, I might be able to achieve my goal at 90%, but I definitely will be able to achieve my goal. Try to think, open your mind. Medicine is no longer the medicine of those days where you have to sit and cram Grant's Atlas of Anatomy. No, especially a specialty like in emergency medicine, it's very dynamic. Question things, open your mind to new ideas. Read up articles. If they come from the US and they did this, well, we don't have that in Uganda. But then what can we do to have a similar outcome in Uganda or Kenya or Nairobi or sorry, Nigeria or Sudan or South Africa or Zambia, Namibia, anywhere? Think, look at your surroundings. What do you have in your immediate surrounding, in your country, or even beyond, that you can tap into to address that issue of limited resources and time? I'm not very good at accepting this LMI issue all the time. Yes, we have less money, but we must think. We have the same brain, we can apply brain, and we can win, all right? The other barrier is, of course, overlapping of roles and duplication of services. You often get the question, so what are you? Are you a surgeon? No, I'm not a surgeon. Are you a physician? No, I'm not a physician. I don't like ward rounds. I can't do morning updates every day, continue treatment, status quo. You have to be able to delineate your role and bring it out clearly. Who are you as an emergency physician? What is your role? Great. So now that we know what a multidisciplinary approach is to emergency care and all this modern healthcare and what it recommends for us to do, can Africa afford this? I'll bring it back to you and I won't give you the answer. Go sit down, think about it. I'll give you my perspective though. So in many of our African settings, we have the sole practitioner culture. You finish your internship, you qualify, you get your license, and off you go to health center 4, that is, or a general hospital, a small general hospital having a population of about 1 million. All right. With your new license, very excited to be a doctor, to finally graduate, to be able to practice independently. And there you are, the only doctor in the facility. So what does that mean for multidisciplinary approach? I've gone through this very colorful continuum for you of, having a first responder, having a tier 1 non-professional responder, having a tier 2 professional ambulance responder, who then goes through and takes the patient to a facility, and there you have a well-trained emergency nurse, an emergency physician, receives the patient, surgeon, neurosurgeon, etc., etc. What happens in our Africa? Most times, you're going to be called and a police vehicle is going to bring an accident victim to your unit. You're the only doctor with maybe a clinical officer if you have one, and a nurse, both not well trained. Remember, in many of our African settings, we still don't have medical students doing emergency medicine in their undergraduate training. So a lot of what you've learned is mostly if you're lucky to have been in an intern setting where your consultant actually shows up and gives you some tips and knowledge and trains you. Sole practitioner. You're going to admit this patient from the police. You're going to stabilize this patient with your nurse. You're going to call theater to ask them to prepare for you. You'll have your one anesthetist there. You probably will not be able to know how to intubate at this stage. And if you need to intubate in the emergency unit, you're going to have to call anesthesia to come and intubate. And your anesthesia may not be an anesthesiologist. It may be a clinical officer who has gone and specialized into anesthesia. He's going to intubate. You're going to go to theater after admitting. You're going to do a bar hole or other procedure, most likely a bar hole, or if it's abdominal, you're going to do the lap. You'll snip off the spleen, etc. You'll do the surgery yourself. You stick this patient back. The patient goes to some sort of post-anesthesia recovery. Anesthetist monitors while you go, get off your scrubs, go and receive the patient in what is the best level of care you can provide, let's say an HDU. You're going to manage that patient. If this patient is too sick, you will probably refer, or you should refer to a tertiary level facility. You might end up sitting on that ambulance to take this patient. If not, your nurse that you worked with in the emergency department will end up sitting in the ambulance with the ambulance driver to deliver this patient X kilometers to the tertiary level facility. That is a reality for many of our African settings. So how does a multidisciplinary approach I described to you, that very nice ideal situation, then fit into our African norm? It doesn't. But I told you, let's apply brain. Let's be resourceful. But let's also advocate and let's try to build our systems. If we don't build systems, then 10 years down the road or 20 years down the road, your child is going to do medicine and they're going to do the exact same thing that you are doing 20 years before them. Wrong, wrong, wrong. That should never happen, all right? Every year should be better. So what can we do in Africa? So multidisciplinary trainings should be incorporated into our clinical practice. That's it. As a doctor, you must understand the role of a nurse. Do not be trained in your silo without knowing what a nurse is supposed to do. Nurses are not just people to follow you around with a book and drugs for you to, say, give orders to. They actually have better roles. They can do more. So what more can they do that you can empower them to do? Medical students. Recently in the COVID pandemic, we were struggling with making calls to people that are positive and counseling them. And then we got a light bulb moment. Oh, we have medical students. They can counsel, they've been trained, they're polite, they're willing to help, they're eager to help. And there we go. We tapped into that. So think, and in their training, they've now been part of this system. So all our clinical practice should not be in silos. We should know what the physiotherapist does. We should have sessions with them in our training. We should know what the nutritionists do. Have some sessions with them, understand their role, and you will know who to call when you need what. I'll go to policymakers. A lot of us are involved in policy, and even students. I'll address the students particularly. Some of you may pick interest in public health. Do not become a certified laptop doctor that does not apply brain. Think about the people you're building these policies for. Put yourself in the clinician's shoes when you're making policies. So policymakers, kindly make it a priority to support clinical, operational, and governance aspects. Sometimes a lot of our policies focus on governance without thinking about the clinical and the operational. It doesn't matter if you have governance alone without the other aspects. They have to work together. Develop an inclusive, multidisciplinary team environment. Work culture, work environment, very, very important. A lot of us grew up in a very hierarchical type of training. When a consultant walks in, you shut up, and the only thing coming out of your mouth is a correct answer. If it feels wrong, you swallow it. That's the type of medicine we grew up. You cannot say good morning, sir, good morning, ma'am. Not good for multidisciplinary teamwork. There's doctors who work 10 years with a nurse, 10 years, and they do not know her name or where she stays. If she has 5 children and her husband is dead and she's struggling and she has to walk 5 kilometers every day and you're busting her for being late. Nurses, your intern works 36 hours. I once had to drink, not once, a couple of times. I had to drink 5% dextrose when I was an intern because I didn't have time to eat. I was just seeing patients, hours and hours. If you're a senior nurse, you see a young doctor, give them a break, allow them to have a break. If a patient is not urgent, manage the patient, work as a team. Don't see a very sick patient coming in and say, that's the doctor's role. I'll just sit here and roll my goals. No. Understand each other's roles, support each other. Have an open culture where people are free to voice their concerns and suggestions. A nurse might see you making a mistake that will cost the patient's life, but because you've created this tense environment where you work that nobody questions you, you will miss that hypoglycemia of 1 and 2 hours and 30 minutes later, you're doing CPR for something you could have reversed very easily and something the nurse could have said, oh, doctor, maybe let's do the random sugar and see what's happening. Thoughts, create a good environment. I'll just quickly go over this slide, and it's a bit heavy, but also not heavy, all right? So I just picked extracts, and the context might be different, but I'll focus on the principle here. And the principle is that we need to work as a team. Our work, no matter if it's a department, or a unit or an individual, complements the other person's work. I won't go into the details because a lot of this I've already spoken about. But if you look at the left, the emergency department, primary care, outpatients, and this specific one was taken from a mental health situation, looking at a patient at risk for suicide. And look at the multidisciplinary approach you need to manage that patient successfully. We know that suicide risk and all this is a mental health emergency. We do manage them in our emergency departments. We manage them in primary care. We manage them in outpatients. We manage them in inpatient. But all this has to create some sort of safety for the patient. Doesn't matter where the patient presents, either in the ED or primary or outpatient or inpatient, okay? We have to work as a team and look at the entire team that it takes: psychiatrists, psychologists, ED, nurses, social workers, case managers, your admin people, everyone. All right. Great. So we'll go to the future. Students are our future. Children, students, you are always our future. So what does the future look like for emergency medicine in Africa? I think it looks bright. It looks very bright, actually. It's a young specialty, very dynamic. It's literally in some places given a clean slate, all right? Or something to paint, like these paintings that my children did on my wall. A nice blank piece of paper, and we can paint anything. You can paint, this is probably a lion. Yeah, you can paint, I don't know what that is they were painting. We can paint whatever we want. We must paint a system, however, that works for our patients, that works for our country, that works for its citizens, that works for any visitors who will come to our country. We must paint a picture that is all-inclusive and that is based on sound principles. Yes, emergency medicine is a bit of everything. You'll find that best 5 minutes of every specialty. Yeah, so if you're like me and you want a bit of everything, this is your medical buffet. Enjoy it. Do emergency medicine. You will become a complete doctor. They call you for trauma, you can manage trauma. They call you for an MI, you will liaise an MI. You just flip a page in your mind, go do a pediatric convulsive patient, go do a neonatal sepsis. You will be able to manage more patients better. There's also various career options along the continent. I've recently been at a crossroads looking at academia and policy. I probably am still there as an individual, but there's many options for me, and there will be many options for you when you graduate. You can do anything. You can do critical care, you can do disaster medicine, you can be a manager, you can go into policies, you can do a lot of other things. There's also opportunities to progress in your career. An EMT, you can do anything up to a PhD level. Do not limit yourself. There's also, and this is my favorite, there's opportunities to be a change agent. Change yourself, be a better person, apply your individual virtues, be kind, apply all of that as an individual, apply it to the system. Change the system where you work. You will change the country and you will change people's lives. I'll give you this nice picture. I'm sure, I just got it from Google, but I'm very sure this was taken in Uganda. It just feels very Ugandan, but probably the Nigerians are thinking the same. Many hands, one mind. That is what we should be as a team. All our hands should function with one single mind that is committed to a specific goal and that is prepared to deliver it. And I'll leave you with my favorite quote in the world. Nelson Mandela. It always seems impossible until it's done. So guys, go out and do it. Thank you very much.
Okay, thank you so much, Dr. Annet. So as you've heard the wise words from her, it's time for us to go into the multidisciplinary approach. You need to know your fellow co-workers, the nurses who work by your side, the physiotherapists, you know, because if you're being honest, some of the doctors out there, you will work, but you will never know who is helping you, who hands you that thermometer, who hands you that scalpel when you need it. So let's grow this culture of a multidisciplinary team where we work together and support each other. And in the long run, we'll be offering a much better service to the public, to our patients. And yes, we'll have a better survival rate. Yes, so now we'll be moving into the plenary discussion where we'll be joined by Dr. Wachira and Dr. Adebisi. I hope you're still there.
Yes, we are.
Yes, we are.
Okay. So we'll be discussing a couple of issues. So first, on the topic of what we want to expound on, we have matters about the current affairs and the current state and the importance of emergency medical care within our continent, Africa. So we want to delve into this and yes, find out how we as Africa are doing. So maybe we can start with Dr. Wachira, if you can give a comment on this.
Thank you very much, Lilian, and very great presentation by Dr. Alenyo, which I think has highlighted essentially what emergency care is about. But I think one of the things that we also need to appreciate is, regardless of the fact that we do not have established systems, emergencies happen every day. Even right now, there's someone who's requiring emergency care. And as a medical student, I'm sure you may have come across a couple of emergencies during your training, and and as soon as you enter into internship, you will be faced with multiple emergencies coming through to the hospital. So currently, unfortunately, despite the fact that the cases are there, so this is not a situation where we don't actually have emergencies. Emergencies exist every day in our system. We've not really worked to develop our systems. And as Annet also highlighted, based on the WHO emergency care system framework. So the difference between other aspects of healthcare is a surgeon is a surgeon. A surgeon will take one patient, go cut the patient, fix the patient, move on. Emergency care is dependent on actually an entire system working together. So from the pre-hospital perspective, all the way into the emergency department, and sometimes even beyond. So most of our healthcare system has been very isolated, very silo-based. So there is HIV, TB, malaria care, there is HIV care, there is this care. So maternal child health is just looked as one component of the healthcare system. So most of our, I'm speaking from Kenya, but I'm feeling most of our African healthcare systems are based on the same. They're actually based on individual lines of care. And look at it from the perspective of even just the hospital. Very little has been done on pre-hospital care. So the thing that we need to look at, and where emergency medicine comes in, is emergency medicine is a continuum. It cuts across the entire healthcare system and it cuts across malaria, it cuts across HIV, maternal child health. So this concept of building the healthcare system has really not existed in many of our systems. And that's why we really remain behind in terms of building an emergency care system.
Yes, thank you. So I'm hoping Dr. Adebisi can pick up on that. Maybe you can talk to us about how we can bring in this factor of incorporating all aspects of healthcare instead of, secluding into surgery. Then we have internal medicine, then we have pediatrics. Like from most of our attendees are students who are still learning. They're yet to go into the world of, giving full-time healthcare. So how can we prompt them such that when they go there, they give a holistic approach into healthcare and how to give care for the patients? And whenever there's an emergency, they won't think of it as, oh my God, this is surgery. It will be holistic. Maybe you can give a comment on that.
Okay, thank you very much. The first thing I would like to say is that the whole premise of the benefit of emergency medicine is the definition of what it is. So emergency medicine is a specialty that entails that there is a group of people, doctors, nurses, and all the other rest of the team who are dedicated to providing urgent, life-saving, time-sensitive care to patients regardless of the presentation and regardless of the age group. So these persons are trained and set in the emergency department of a facility, a clinic, or a hospital, and they offer care to people with urgent presentations and in emergencies, regardless of whatever the presentation is, and they help direct those people to the specialist from whom they will receive definitive care. So saying that is that just brings to light the importance of having emergency physicians in every working healthcare system. When you think about the healthcare system, it is a holistic. We think about it as a holistic provision, a holistic system that provides care on a continuum. So a patient presents in whatever form, and there's someone who receives them and sends them along till they receive the exact care that they need till they are discharged. So when we think about it, we should think about it from the patient's point of view. The patient doesn't know whether they should be receiving care from a surgeon or from a medical doctor or from whoever, but we know. So the healthcare system should be organized in such a way that it maximizes the patients reap the most benefits. And to provide that kind of system where patients are prioritized as like everything we do is patient-centered, emergency physicians have to have a place, because that is the only way they can receive the care that is best for them. So just looking at it from the patient's point of view and looking at it from a patient-centered point of view, that's the way to look at it, to think about providing care in a continuum where every system is, every specialty is well represented. And that patient receives only one presentation. A patient might need specialty care for more than one specialty, and it's a common thing that is seen. So I guess that's one way to put it.
Okay, thank you so much. Then Dr. Alenyo, so maybe you can take the next. So I wanted you to comment on, as Dr. Adebisi has said, whereby we want the patient to get care right from the onset when, for example, like you said, there was an emergency on the road. So from the pre-hospital care perspective, right down to when the patient gets into the emergency department and then maybe is resuscitated, taken into theater, then maybe taken into ICU. So what can we do as a continent in Africa to improve the quality, like for example, train more pre-hospital specialists, the paramedics, so the person who will see this patient while he's being picked from that road to be brought to hospital. What can we do as upcoming medical practitioners to improve the services delivered?
Great. Thank you, Lilian, for that. As a student, would you like me to answer as a student?
Yes, you can.
I haven't done that in a while.
From the perspective of a student, right to the intern, to the MO.
So I think one, we must demand better of ourselves. We must, wherever we are, think about the patient. Whatever we do, all your medical training, your nice stethoscope, your white coat, your tables of anatomy and embryology, whatever you've crammed, all those nerves and how they split. The overall for all of this is patients. All of it, it boils down to the patient. So let's be the best that we can. Let's practice ethical, responsive medicine. As a student, learn, be inquisitive, network, make friends. I see lots of countries on the chart. Find out what people are doing in other countries around the world, because you are the future. So you need to think of when you're wearing those big shoes, what would you like to see? And it starts when you're very, very, very young in medicine. You have to see the future. You have to want it. You have to want more and better for your patient. Do not allow or do not stand by while patients walk into your ED and nobody responds to them. Do not become that doctor. Don't let that seed seep into you. Don't graduate with those vices. Demand better from your consultants. If a patient walks and no one is responding, and you ask, why are we not responding to that? That looks like an emergency. Oh, better still, respond. So we have to be the change we want to be, essentially, is what I'm saying, from a student perspective. But I see that on the chart, there's more than just students. So for the people that are not students, for those that have already graduated, for those that are already working, what do you want to see in your health system? You know it. What I presented, that ideal situation, is the WHO Emergency Care System Framework. You can Google it, read about this. Be interested in what's happening. Has there been a policy passed? What does it say? What does it mean for us? And advocate, advocate, advocate. Don't stop advocating. Be your patient's voice. And that's how we are going to change it. Because one day, you will be the patient and you will not have told people around you to speak up, and then nobody will speak up for you. And you will die with a hypoglycemia of 1 that could have been reversed and you could be alive. Yeah, so I think that summarizes it. Thank you, Lilian.
Okay, then also Dr. Annet, just on that, could you also comment on the importance of emergency care policies and how they will aid us to improve the quality and availability of emergency care available?
All right, so I'm going to try to teach now. So if you don't have a code, if you go to a secondary school And I'll give you two secondary schools. Secondary school A, they have a standard. You come to school at 8, by 8, you're seated in your class, you're wearing uniform. Our uniform consists of a white shirt, blue shorts or a blue skirt, white socks, black shoes, clean, neat, well-pressed or well-ironed, and you're ready for class. School B, no rules. You can walk in whenever you want. You can sit under the tree, in the class, on top of the teacher's desk. You can do whatever you want, as long as there's some sort of teaching, someone comes in and gives some sort of lecture, people listen, whether they learn or not, doesn't really matter. But something happens, a school bell goes on, goes off, people go home. School A and school B. School A, bring it to a system with a policy that says for ABCD in our setting, this is the standard. So everyone is then forced to comply to that standard. If we say an ambulance must have X, Y, and Z, then everyone will comply, whether it's private ambulance, whether it's a public ambulance, it doesn't matter. They will all know the standard for an ambulance in this country is oxygen, a monitor, a patient stretcher, a well-trained emergency care provider, etc. On the other hand, you have a country that has not regulated what should an ambulance be like. And so a member of parliament will buy an IPSAM, write on ambulance, put it on the road and say, I bought an ambulance. So you see the difference. Having policies and all this, they control the quality of healthcare we provide. They push people to provide a certain level of quality, and they provide guidance. If I'm opening up a new clinic, I want to do an emergency center, I don't know what it should be. I'll look at the policy. What does the policy say about an emergency center, for example? It says ABCD. What does it say about governance? It says this. So you have a blueprint within which you can work and produce better quality. If you don't have a policy, on the other hand, anyone does whatever they want. If they do it well, if they don't do it well, you cannot hold them accountable. They can slide. But if you have a policy, we have accountability and everyone is held accountable for what they're doing. Thank you.
Okay, thank you. Then also on that, we want to delve into this thing called universal healthcare and how there are new policies and ways that we want to incorporate universal healthcare into our medical practice, such that this basic healthcare that everybody is, let's say, has a right to, right? So how does universal healthcare come in? How does it assist us to provide, for example, an emergency where you have a patient who comes in? How does universal healthcare assist us in providing emergent medical care?
Ben, do you want to take out that one?
Yes, I was thinking Dr. Wachira.
Thank you, Annet. So there are two aspects of it. And I'll just continue from where Annet was speaking on in terms of policies. We have, for example, Ministry of Health just launched released the Kenya Emergency Medical Care Policy 2020-2030. Our constitution has very great legislation around emergency medical care. Also the Health Act 2017. It's very pretty on paper. Similarly, when they were working on the universal healthcare coverage program, we were involved, and emergency care and emergency evacuation is part of universal healthcare coverage, with the idea that every Kenyan will have access to universal emergency care coverage, ranging from evacuation all the way through to treatment in the emergency department. And a lot of this has been put in paper. Yes, the idea, emergency care, first of all, is a right. Is a right to every, this the same way healthcare is a right for every citizen in any country. Emergency care is definitely a right, and that needs to be provided. And this mainly needs to be provided by the government and put in the legislation and as part of universal healthcare coverage. because people can't choose when they're having emergencies, and it's not always that you'll be able to have the funds to provide emergency care, well, to pay for the emergency care services. And that's why it needs really to be incorporated as part of the government structure. So I think key thing behind policies, as Annet mentioned, is policies are a good guidance. And we have fantastic papers, policies, guidelines, and all in Kenya. But the gap that exists, at least in our setting here, is the implementation. If everything were to be implemented as prescribed in the Constitution, Health Act, Emergency Care Policy, Universal Healthcare Coverage Plan, then Kenya would be having fantastic emergency care services. But we all know that's not the situation at the moment. So emergency care should be part of any UHC program in any country, and is key to ensure that everyone is able to access care at any time, 24/7, 365, regardless of ability to pay. But this also, beyond developing all the policies and the paperwork, there's need for this to be implemented. Structures are actively put in place, and key important, especially when it comes to government, is the funding made available to ensure that it's something that will be readily accessible to all within the population.
Okay, thank you very much, Dr. Wachira. Then Dr. Adebisi, maybe you can comment on the knowledge and how to increase knowledge in the general public about the availability of universal healthcare and how it can help, for example, in an emergency situation, how universal healthcare, instead of, let's say, people going to a local clinic where you have an emergency and the clinic cannot take care of you well. So when they go there, they're referred to the next healthcare facility that can handle this emergency, and how universal healthcare can help us to increase and better this referral system, so that we don't have so many fatalities, because maybe the given patient is too scared of going to the next facility that will provide better services.
Okay, thank you very much, Lilian, for that question. And just building on what Dr. Wachira said about universal healthcare being a must, emergency medicine, emergency care being covered as a must under universal healthcare, I just want to say that universal healthcare is for everyone, both for the rich and for the poor. It benefits everyone, and most especially in emergencies. And this is something that I have seen happen in real life, that persons come to the hospital to receive emergency care, and they do have the money to pay. But when you talk about systems of payment affecting the ability to receive emergency care, I have seen this real life. So somebody has money to pay, but for one reason, network is down and the person cannot transfer the money or cannot go to a bank to get money at the whatever time of the night was required to bring the money. So universal healthcare benefits everyone, whether you can afford healthcare or not, and most especially in emergency. So emergency care must be covered under universal healthcare. If we're going to see the kind of benefits and to see emergency care being offered as a human right, as was earlier mentioned, I think the WHO already said something about that. Emergency care should be a part of human rights, and everyone has a right to receive care during emergencies and during urgencies when they are liable to lose their lives if they do not receive that form of care. So therefore, the only way we can provide that care as a human right to everyone, regardless of your socioeconomic status, it must be covered under universal health care. Now, when we want to raise the awareness of universal health care, there are a lot of challenges in that aspect, and also a lot of work to be done. I would use my country as an example. I do not know how universal health care runs in other countries, but in my own country, it runs under something called the National Health Insurance Scheme, and that is like the scheme. That is the scheme we're trying to use in providing care to everyone, regardless of socioeconomic status. But this National Health Insurance Scheme only covers about 1% of the Nigerian population. So we can see how ineffective that scheme is, because it's not even covering up to half, just 1%, and those are just the people who are employed in government positions who have access to the National Health Insurance Scheme. When we want to, if we want to really improve this awareness, we need grassroots action to help take the information of insurance schemes and insurance insurance projects or any form of insurance funding available to people who do not even have any source of information to access that. I'm talking about people who are not educated, people who live in rural areas who do not even know there is any such thing as a national health insurance scheme available that they can subscribe to receive care. So we need definitely grassroots action, most especially in rural areas and to people who are underserved, to have that access to that information and to be able to access that care. Thank you.
Okay, thank you. Then I'm seeing we have a question in the Q&A. Maybe Dr. Wachira, you can tackle this, where we have a question about what is the role of dental emergency care in Africa?
Yes, thank you, Lilian. I just typed it out. But essentially, emergency care, and that's the beauty about emergency care, is it affects everyone. And across, there's dental emergency care, there's maternal emergency care, there's surgical emergency care. So all aspects of healthcare system are affected by the need for emergency medical care services. And beyond the need to ensure that all healthcare providers, dentists included, have a basic training on how to provide emergency care, basic emergency care in their setting. So for specifically like in this one, it's in the dental practice. All dentists before graduation should be able to undergo a basic training on how to initiate emergency care in case a patient does collapse or something happens in the dental practice. But beyond this, there's a need to also ensure that there is a system where that the dentist, as they initiate the initial care, they're able to call on this system, what Annet was describing in her presentation, this phone number where you can call an emergency care center or a dispatch center. They will be able to provide you some more information of what you can do, but are also sending you an ambulance which has trained providers who will then come and assist the dentist in stabilizing the patient and then transporting the patient to the emergency department. So every healthcare provider must understand how to initiate basic emergency care, whether you're a doctor, nurse, clinical officer, or pharmacist, whoever. You should be able to know how to initiate basic emergency care. But to support this, there's also a need to have a system that you can now reach out to through a quick phone call that then is able to help with providing you with additional information, but also bring in trained providers who then can continue the care you've initiated and take you to an emergency center.
Okay, thank you so much. Then Dr. Annet, I remember you had mentioned earlier on about how there's the problem of we have increased fatalities due to poor emergency health services. So could you comment on this aspect of a referral system? What can we do in the emergency medical care setting, whereby if, let's say, a patient has been taken to a clinic or a dispensary and they clearly cannot handle the emergency, how best can we improve the referral system so that the patient is transferred to the next available hospital that can handle the emergency so that they take action on time before we have a fatality?
Lilian, referrals are perhaps one of my most favorite system topics in the whole world, literally. I love referrals because if done well, very good outcomes. If done badly, complete mayhem, poor outcomes, complete chaos, and it can just frustrate everybody. Can you imagine if you're in a tertiary level and people bring in patients, SATs of 70, SATs of 50, SATs of 20, and they're just down the road, they haven't called you, they haven't told you about this patient, your hospital becomes full, you don't know who else is coming in, what they're coming in with, complete chaos. And most importantly, poor patient outcomes. And referral doesn't have to be complicated. Very, very simple. Does your unit have one single number that whoever wants to access the unit or reach the unit can call? The problem now is referral systems are in people's pocket. I have to call the hospital administrator. If I don't call the administrator or if his phone is off, that's it, blackout. I cannot reach the hospital. Why? Why are we carrying our referral systems in our pockets and with our friends and in our individuals? I don't have to refer because, oh, I know I have a friend who works in that hospital, I'll get a referral. No. Referrals are standard. If you cannot manage a patient, you refer. Clear principles. 1, recognize a patient you cannot manage in your facility very early. Don't wait for an MI to start showing you tombstones and patient is going into cardiogenic shock before you say, oh, I don't think we can manage that. Or don't wait for a child who comes in with massive bouts of diarrhea to go into shock for you to say, I don't think we can manage this, all right? So early recognition, very important. Access, very, very simple when you're referring. Simply have a list in your unit of all the clinics and hospitals and higher facilities you refer to, even the lower ones, so that if you need to reach them, you just seem to pick up a phone and call that number. And that means you must also have a number if people need to reach you. And that number should not be the director's number, the head of department's number, the sister in charge's number. No, 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 no. One number in the unit, everyone answers the phone. It's the same number, everyone knows it, the community knows it, the nurses know it, the doctors, the porters, the cleaners. When you're discharging, you write that number in the discharge note. Everyone knows that number. We don't have things like 911 systems in our country where, you know, you don't have to think a lot, you just call 911. But I told you, we have to apply brain. Think, it's very simple, okay? People need to discuss. I've had very interesting discussions. So I sit on the COVID task force, and I've had very interesting experiences in getting patients referred. And people are writing half a line and a patient comes in and it's an ICU patient. What is that? Have a standard referral form that forces whoever is referring to provide certain specific information that is going to be important for the transfer of care, the transition of care from you through the ambulance team to the receiving facility. Very simple things. So have a system, map out your area, know what level of facilities are there. We have 2 general hospitals, we have 1 tertiary, etc. We have 5 lower facilities. Know their numbers, know how to reach them. The numbers should be on all the time. 2, have a structured referral process, and everyone should know it. How is a referral made? You pick a phone, you call, you confirm a doctor, accepts the patient, you document. You write a referral form, you give it to the patient, you call the ambulance, your hospital has an ambulance, you activate your internal ambulance activation process, you get the patient goes. And referrals are never complete without feedback. And that's something we do very badly. People need feedback. Oh, guys, the patient you referred with XYZ, it was actually ABC. And this is what we did. This is how we found out. In future, when this happens, consider this. It might help. Or if you had actually given a little fluid, this patient would have done better when they came. Have a discussion post-referral. Look back to the referring system. Simple things. List of names, 1 uniform number, a referral form, and everyone knows how the system works. Very simple system. And that's it. You don't need complex things. 911, hello, what's your emergency? You don't need all of that, okay? I hope we reach there one day. I sincerely hope we reach there one day. But before we do, there's a lot we can do that will work just fine and is not expensive. Thank you.
Okay, thank you also. So I'm seeing there is a question directed to Dr. Adebisi. I don't know if you can address it.
Okay,
Hello?
just so much, Dr. Annet, for your answer. I really learned a lot about the whole process of what the referral system should look like. I'm not yet in practice, I'm still a medical student, so really I do not have much on hand experiences, just about maybe theoretical knowledge I have at this point and maybe learning from other people's experiences. So it was really nice to hear how you described the whole process of the referral system. Just to also add something, not necessarily to the referral system, but the concept of destination triad. And as a medical student going to the emergency room to work, I've seen ambulances come in many times to the emergency department, at my different places. Another patient has been from one place to another that we had. From the paramedics and those who operate the pre-hospital system should also be trained appropriately on how and where to take patients when they are called. So when they are called from a home or from a scene of an accident and they go to visit the patient there, they should have adequate training on how to triage what destination they should take that patient to, what hospital would best has the resources to best support that case presentation, and what the victim or the patient is presenting with. So that is another concept, and this should also be done carefully so that they do not over triage and always take patients to the higher level, higher tier facility. So I just wanted to add that point to that. So the question that we mentioned that was asked, I can't find the question.
Okay, maybe I can read it out. So it says, is there a system that can be put in place to ensure that the National Health Insurance Scheme covers at least 90% of population? And maybe if it can be replicated to other countries within the continent.
Okay, thank you for that question. I am not necessarily an insurance expert, but what I would see is that we need to leverage institutional.
Hello, Dr. Adebisi. I think you're breaking up. I think it's the internet. Dr.
Leverage structures that we have already. So in terms of I guess the internet as well.
Hello? Can you hear me, Dr. Adebisi? Okay, as we wait for Dr. Adebisi to reconnect, maybe Dr. Wachira, you can comment on the issue about the referral system and how to improve access to timely care. Maybe you can give a small comment to add on.
All right, and I think, to be honest, I wouldn't have much to add from what Annet has mentioned, but the key thing is one of the things that people need to understand in any healthcare system, and one of the things really I'm working on with our government here, is not every hospital can provide emergency care. You cannot present with a heart attack in a dispensary and expect emergency care services. And oops, am I still audible?
Yes, we can hear you.
Sorry. Yes. So not every facility can provide emergency care. And this is one of the things that needs to be defined in our healthcare system is, where do you go when you're having an emergency? If you've been hit by a bus, going to a healthcare center just delays your time to get into a proper facility where you need definitive care. And if you're bleeding, time is life. And thus there's a need for us to look at our healthcare system and across every part of the country, wherever you are, and have clearly defined, demarcated emergency care centers. So even before we start the ambulance services, because right now we all take ourselves to hospital in our private cars and our public transport systems, we need to know where to go when you're having an emergency. This needs to be clearly defined so that people know, if I'm having an emergency, this is where I need to go. Because that will actually also potentially save a lot of patients, because we get patients who've moved from hospital to hospital to hospital. By the time they actually get into a center that can do something, so much time has been wasted, and patients potentially are beyond care at that point. In the same breath, the idea of developing an emergency medical services system, the ambulance system, this is part of that structure. The providers who work within ambulances, the development of that system ensures that the providers are trained to know how to assess every patient and to know which hospital to specifically take a patient as they present. So if this patient is presenting with a heart attack, this is the hospital to go to. If this patient has been hit by a bus, this is the hospital to go to. If this child is having a severe infection, this is the hospital to go to. This is part of their training and part of the components that have been built into the system. And that's the importance of actually building a proper emergency medical services system. So EMS, ambulance system, calling it referral system, but that pre-hospital system needs to be well have trained providers so that then it's not necessarily the responsibility of the person who's busy trying to die to try and figure out which hospital to go to. They call this number, and this number then is able to send an ambulance. At least in the good setting, it will send an ambulance that will come and take this person to the proper hospital. But even if that ambulance system is not there, just having that number where I call and say, oh, I'm having a bit of chest pain. The person on the other side of the phone can tell me, all right, where are you? You're in Makueni. Okay, the best place for you to go when you're having a chest pain is this hospital in Makueni. So not just land in any hospital. So that's the importance of having that system. Even if you're not going to have the whole healthcare system or the whole system built in, just that help and that phone number is a key component that needs to start. And if you were to ask me, in any of our healthcare systems across Africa, that's the first that should be instituted. So that, I know ambulances are expensive and things like that are expensive, but having a phone number people can call when they need help will go a long way in saving many people's lives.
Okay, thank you very much. So Dr. Annet is requesting if she can step out a bit. She has a meeting. So I wanted if she could just tackle the issue on opportunities available for healthcare students and other practitioners who are interested in emergency medicine and how they can join that field of medicine.
All right, great, thank you. And I apologize, we have a bit of a situation here that will require me to join the team. Ben, while I'm commenting, do you think you could quickly find the link for the AFEM membership? Could help me post it on the chat.
All right.
So there's lots of opportunities for students. I think this has been a great conference, and I'm very impressed. I never got to attend things like this when I was younger. But of course, the first thing I think is you need to learn how to network before you think about opportunities and growth. You need to learn how to make friends, keep in touch with them. Have mentors. You're still very young, there's a lot to learn, but you've got a lot of energy, which can be very useful. And so you need that energy to be directed appropriately and at the right level, not too much, not too little, too much sometimes. You need a mentor. When you have those in place, you have mentorship, you can network, and not just networking, any other soft skills. Learn how to use Excel, learn how to use Microsoft Word properly, learn how to do a Zoom call, etc. Learn those few soft skills, they help. They will help you to tap into opportunities. Mentors know lots of people. They'll help, push you when there's an opportunity for a student to present something. And once you nudge gently and you present, it then opens up, another thing and another thing. You're not going to get opportunities if you sit back in your silo and dream. You need to work hard, all right? So nothing comes by sitting and wishing, wishful thinking, no, no, no. You need to work hard, you need to be intentional, all right? So what opportunities can you then have? Of course, lots of you like conferences. You can go for conferences, and in conferences, if you go, make sure you meet people. You might find your MEd professor there, your master's professor, or a PhD professor there. There is opportunities to participate in medical students special interest group in Africa, emergency medicine special interest group for medical students in Africa, under the African Federation for Emergency Medicine. So Ben has put up the link for you to register as a member of the African Federation for Emergency Medicine, 100% free. Despite me working, I also still don't pay for this. Ben doesn't pay for this. It's completely free. So just click that link and become a member of AFEM. Under AFEM, there's a nice new drive by a number of students. I think Adebisi, you're one of them, that is leading a charge to have a special interest group that looks at emergency medicine for undergraduate medical students. And if you join AFEM and get into that group, there is a lot you can do. there's a curriculum being developed for, emergency medicine for medical students under AFEM, and discussions will be had with various medical schools to see if this can be adopted. So you learn emergency medicine in your undergrad rotations. Also, for those that are postgrad students, there is a special interest group that's already established under AFEM. It's called Delta, and Delta means change. And they have a lot of activities. They have their on-site streams when we have conferences. They network, they have mentorship, they do cases on their WhatsApp group, they discuss challenging cases, they do a lot of things. So there's a lot of opportunity for you to grow and interact. And there's also the IFEM side of it, the International Federation for Emergency Medicine. All the different continents have their sort of student emergency medicine groups. So if you join one group that is organized, you can then be able to interact with these various groups at that level and do a lot of things, change the world, do advocacy drives, do road safety drive, do anything. I told you, it only seems impossible until it's done. So think about what you want to do. And the rest of us are always here in the background to help. If you need help, you can send us an email, send us a WhatsApp message. Ben is very available. I'm available. We can provide some guidance. There's also lots of other people around Africa. Some of them are on the chat, and you can get to know them through AFEM or through other means. So yeah, a lot of opportunities for students to be part of developing evidence-based accessible emergency care across Africa.
Yeah.
Okay. Thank you very much for that comment. So we're also hoping you could give us a final remark just before you leave. Any
Lilian, what final remark?
We have so many people here who are impressed by your words. So maybe a goodbye and a few words to inspire them to join this field. Oh, and there's someone who's asking for your email.
Type my email, and thank you all for the kind words. Guys, we have to change. Africa is not going to change on its own, hey? It's not. It's not. No one is going to come from somewhere and change it for us. So what Africa do you want to see as far as emergency care is concerned? Think about that Africa. Think about what you as an individual can bring to that Africa. Join a group that will help you amplify that, a group that sees the same vision, and will change Africa.
Okay, thank you very much, Dr. Alenyo, for your inputs during this session. And I hope you have a lovely afternoon and the rest of your day. And yes, hope we'll see you again in another session.
Yeah, sure. Thank you all. It's been a pleasure meeting you all, and enjoy the rest of the session. Bye, and bye to the rest of the panelists. Thank you.
Bye, Dr. Annet.
Bye, Annet.
Okay, thank you. So, Dr. Benjamin, I'm seeing a couple of people are requesting for the link to be resent.
Yeah,
some didn't receive.
I've been resending it on the chat there over and over again. So
okay.
Yes.
Hopefully they'll get one of them.
Yes.
So, okay, so maybe Dr. Adebisi, you are commenting on something before network became an issue.
Yes. So sorry about that, everyone.
It's okay.
Talking where I live is really bad, and it just comes and goes off as it likes. So I was talking about the insurance. Somebody asked about how we can increase coverage with the health insurance scheme to about 90%. And I was saying that I'm not an insurance expert, but this is what I think. So we have, let me just roughly divide the Nigerian population, for example, into two sets of people. We have and this is just a theoretic division. We have people who are working, who have jobs and who work in an institution or in a company. And let's just assume there are other people who are in the rural areas who do not necessarily have a recognized or documented type of job. Maybe they just do something menial, or they work on their own or run a business. So assuming we have this kind of structure, one thing we can do is we can leverage institutional structures that currently exist. So we can say all those who work in banks, all those who work in social companies, all those who work in schools, all teachers, all lecturers should have access, and then we would put that not really a burden, but would hold the head or the administration of that institution or those companies responsible for making sure that every member, every staff, everyone employed in their companies do have access to the National Health Insurance Scheme. So it will be like a prerogative on administrations of companies of whatsoever the structure of the institution is, that every staff under them is registered under the National Health Insurance Scheme. Now, for those who do not necessarily work in institutions, or who do not have anything that is recognized in any way, then we might have to leverage communities. So we know that in my country, especially in the rural areas, they have communities, and we have community leaders, local traditional community leaders. You can leverage such leadership platforms to get access to the people in those communities to receive information, and they do listen to the traditional leaders very well. Many of them actually take the advice, or whatever if you want to do something, you want it to be successful, you need to go through the traditional leaders of those small communities, especially in rural areas, and you will definitely get access to the people to sign up and register on the National Health Insurance Scheme. So that is my idea of rural urban kind of. You definitely have to use different forms of different methods to be able to access different kinds of people in the different geographical locations in Nigeria. I do not know how successful it will be if it will get up to 90 people registered, but I think it will help us get better than where we are currently. And permit me to comment on opportunities for medical students in emergency medicine. Can I go ahead, please?
Just a minute. I'm seeing there's someone who's had their hand raised for a while. Okay, wait. It's gone. Yes. Maybe you can just unmute. NUNSA National President. I'm seeing your hand is raised.
Okay, thank you very much for this wonderful and great opportunity. I would like to say kudos to those that are behind this program. We are really glad and we are learning. So I am Nurse Ruben Marcus Draghi, the National President of the Nigerian University Nursing Student Association. So my question goes like this: what is the roles of nurses and midwife and nursing students in achieving the goal of the African at 2063? And how can we aim to motivate and build the capacity and include them as part of the decision making in order to achieve this kind of goal on health for all?
Maybe we can start with Dr. Wachira. You can comment on that, then Dr. Adebisi.
So nurses are a key component of any emergency care system. And the main thing is there's actually emergency nursing as a subspecialty of nursing at both higher diploma level, master's level, even at PhD level. And the nurses are pretty much the backbone of every emergency, or of the whole healthcare system. But in emergency care, I think we really appreciate them more because they save more lives sometimes than some of us clinicians. So the nurses, and there's a need for more and more nurses to go into emergency nursing to ensure that they have the knowledge and skills required to work in emergency care services. But also a lot of nurses, I know in our setting, a lot of nurses are also venturing into pre-hospital care and becoming critical care nurses in the pre-hospital services, so as paramedics or as EMTs. So the nurses and emergency nursing needs really to grow. And I would want to urge the previous speaker to look at their setting and see, is there an emergency nursing society, or how is emergency nursing growing there? Because they are a huge component of emergency care. And if we were to achieve universal emergency care coverage across many of our healthcare systems, then a lot of these people need to be part of the system and need to be developed. So emergency nursing, emergency clinical officers, emergency doctors. So it's the whole emergency care will not develop because we just developed doctors or we just developed one cadre. Emergency care is a system, and without the other parts of the system, then it doesn't work.
Okay, thank you. Then Dr. Adebisi, do you have anything to comment on that?
not necessarily. Dr. Wachira said most of what is to be said about it, that the nurses are definitely a very important aspect, very important workforce needed to really push emergency medicine to the best that it can be, and there definitely should be a part. I think many countries already do have an emergency nursing association, and that is already booming in many places. So I think Dr. Wachira already said, I think, what should be said about it. Yes.
Okay, thank you. Then we also have a session tomorrow on this agenda, the 2063 agenda. So maybe you can also join tomorrow's session and they'll expound more on the matter.
Okay.
Okay.
Thank you very much.
Thank you for the question. Then, so maybe Dr. Adebisi, you can tackle the issue of the opportunities available in emergency medicine.
Okay, thank you so much. I feel like this is really the question that I came very prepared for, being a medical student myself. What I would like to say is that the opportunities vary depending on where you live. For some of us, like I live in a country where we do not have an emergency medicine specialty really recognized, and there's no training, there's no specialized training for doctors who want to go into emergency medicine yet. So it's really difficult. When we talk about mentorship, who do you identify? There is no faculty of emergency medicine. There are no consultants really that you can say have identified. In my own medical school, there is none at all. In some medical schools, there's one person who trained in a foreign country and came back to practice emergency medicine there. So really, if you're from a country
Hello, Dr. Adebisi. I think network issues again. Maybe
where you
Dr.
don't have an emergency medicine residency or faculty members. So what I did was I identified other Nigerians who were working in other countries or receiving training in other countries, and I spoke to them about mentorship, and I was able to secure mentors from that aspect. So I looked outside the country because I couldn't find anybody within my own country as at that time when I was trying to find a mentor to mentor me. So I found someone who is a Nigerian but receiving training elsewhere to be a mentor to me. So you do need to get a mentor, but you just have to look probably beyond where you are at this point. Another thing you can do is to join interest groups. So recently we just started the emergency medicine interest group in Nigeria, but before that existed, there was not. I had searched that, is there any form or any group of medical students who are interested in emergency medicine? I didn't find, and I decided to create one so that we can pull together ourselves. And it was really difficult. We had to open it wide to the entire country to find the people who are really interested in emergency medicine. Because in an institution or a medical school, you might have just one or two persons who are interested in emergency medicine because of how the awareness is so poor here in Nigeria. So you need to find an emergency medicine interest group. If you do not have one in your country, start one. Find a way. Network with people outside your country, ask them how they did it, ask for information of how they put together their own emergency medicine interest group and create one. I think that would be a good way to go. We did it, and now we're really reaping the benefits of having an emergency medicine interest group here in Nigeria. Another thing you can do is to really help improve what I did even before I knew how to go about emergency medicine as a specialty was to go to my emergency department. There's no faculty, there's no training going on there, but I go there to assist, go there to help. I volunteer at my own emergency department in my medical school, going frequently. I wanted to really know if I was really interested and I could handle what an emergency department would look like. And that really helped me in cementing my interest and also, proving to myself that this is something I can actually do. You can also intern do your electives. So you might not have an elective in emergency medicine within your country, but you can go for an elective or emergency medicine internship in another country during your breaks or during school time, when you do it out of school time, during summer or whatever your school breaks. Whenever your school breaks, you can go for an internship or an elective rotation, clinical rotation in another country, in another African country, in Ghana, in Kenya, in Uganda, in South Africa, wherever you know that they do have emergency medicine training and faculty members, and go and see how emergency medicine is practiced in established centers. Something else you may want to do is volunteer, and this has also really helped me. So you can volunteer with organizations that are training lay first responders, and there are quite a number of them in Nigeria. Some are even established by medical students who came together and said, we can't allow things to be like this anymore. Let's do something about it. And so people came together and started NGOs where they are training laymen, bus riders, cab riders, teachers in schools on first aid and first response. And you can volunteer with an organization like that, become a trainer for first aid, become a trainer for CPR and use of the AED, become a trainer for BLS, if you have the competency and you have the certification.
Hello, Dr. Adebisi. Hello. There seems to be a bit of a disconnection. Hello? Can you hear me?
Yes, I can, but I think she's having issues with the network.
Oh, okay. Maybe you can tackle the question as I try to side chat her.
Okay. Sorry, I think I got lost in the discussion.
We are basically opportunities available for students and any healthcare practitioners interested in emergency medicine.
I think that's a very key question, and it's something we all need to think about. If you went into healthcare to save lives, then you're in the right discussion right here. Because emergency care does save lives. That's, I think, my first point. My second point is emergencies, you as a healthcare provider, especially wherever you are, so you could be easily at your workplace, you will be faced with an emergency at one point. And everyone knows you as Daktari Bingwa, the big doctor. And it will be not a good thing if you cannot handle an emergency. And the sad part of it sometimes is also, I think everyone here in this forum, and I'd like to see anyone put up their hand if they've not, has potentially experienced or come across an emergency care. Hi, Adebisi, sorry, just discussing how everyone should get involved and why everyone should get involved. Everyone has experienced an emergency at some point. It may be have been someone personal or a relative or a friend. And I'm sure we've all appreciated the consequences of not having an emergency care system. So I always tell people, I may go through life without having a heart attack. I may go through life without needing surgery. Or I may go through life without needing, I don't know, a kidney specialist. But it's very hard for us to go through life without needing emergency care services as individuals or potentially someone we love. And it's up to all of us within the healthcare system, whether we really are going into emergency medicine or not, to actually really work towards ensuring that we are building this emergency care system, because it's the same system that will save your life, the life of a loved one. And it's the same system that will make sure that even the surgeon gets their patients, or the person needing a heart attack, the cardiologist gets their patients to provide the treatment for heart attacks. So it's a responsibility of all of us as healthcare providers, especially if we went into healthcare to save lives, to actually look at how do we really work into building an emergency care system in our setting. And it's not, I know a lot of people are thinking, oh, maybe now I need to go into emergency nursing, maybe now I need to go into emergency medicine, maybe now I need to look at emergency dentistry. And true, I mean, it's good to think about going into the specialty, but from what I've been saying from the word go is emergencies occur every day, and you do not need to subspecialize to understand emergency care, because emergency care is in your face every day. What we need is people to start looking at their environment and how they can contribute to putting in the appropriate infrastructure, gaining the appropriate knowledge, even as a nurse, a doctor, a pharmacist, on basic. And the good thing about the internet right now is all this information is online. All this information can be accessed through Google. And we all have an opportunity to understand emergency care, advocate for emergency care, and just maybe the life that will be saved from the work that you do will be yours or someone else's that you love.
Okay, thank you very much. And I'm also seeing a couple of questions in the chat. People are interested in joining the Emergency Medical Kenya Foundation. So maybe you can comment on how someone can do that.
All right, I've put the link for the Emergency Medicine Kenya Foundation. So we're a nonprofit that really works towards strengthening emergency care within the country and working with all providers, from students all the way to practicing clinicians, and mainly working with the government and both national and county government to ensure we can develop an emergency care system here in the country. And we definitely need your support. As students, we have a lot of educational resources that are freely and openly accessible. I know we have emergency care protocols that you can download from our site that will help you as a provider on the front line to provide emergency care. And that's what I'm saying. You don't need to go to the knowledge is already there. As I'd mentioned, Lilian, we will be giving out free protocols for the people, for the interns who are joining in into the workforce. So there is a lot. There is a lot that everyone can participate, and you're more than welcome to join the foundation. I've put the link on the chat there, and engage with us as we work towards strengthening emergency care in Kenya.
Okay, thank you very much. So as we are winding down, maybe Dr. Adebisi, you can finish your commenting on opportunities, and also I'm seeing a couple of people are interested in joining your group, the emergency interest group. So you can also comment on how someone can join.
Okay, thank you so much for the question that you asked, for the opportunity to also. I'm so sorry, guys, for my network. I really apologize, and I'm really sorry about it. Yes, so about the opportunities as well, research. Medical students, you do have a place, and there's a lot of role you can play in expanding and increasing the amount of research publications and available information on emergency medicine. So you can find a team of other fellow interested emergency medicine bound medical students, come together as a group and do a research. So what I and my friends do, I have a group of emergency medicine bound friends as well. And what we do is we identify a coming conference and say, oh, there's this conference coming up. What can we do? Because we do have a list of research topics that we want to do, and we look at which one can we do in the time frame that we have. And then we go ahead, put in all our resources, put in our time, and then we try to carry out that research before the conference comes so we can submit an abstract. So opportunities are bound only if you're really ready to work, because being a new specialty, there's a lot of opportunity, but there's also a lot of work to be done as well. So I think I've mentioned quite a number of them. And then there are also so many roles for leadership and development of emergency medicine in all African countries. As medical students, many of them do not have student organizations. Even those who have student organizations are looking to expand to other medical schools. Like in my country, we have only one interest group now, and we hope in the future that every medical school would have an emergency medicine interest group dedicated to that school and to the medical students who want to pursue a career in emergency medicine from that medical school. So there are also still so many opportunities to expand and to, in leadership and development, and you can take advantage of these opportunities. Speak to someone. If you have an idea, speak to someone, anyone who you think might be able to help you actualize it. And that's what we're doing currently. Also, the AFEM Medical Student Council is in the works, and we're really developing that, and we call every emergency medicine bound medical student to please watch out for the African Federation of Emergency Medicine Medical Student Council that will soon be throwing open to everyone to join officially and register, have you in the database, and even to be a part of developing and growing that in the nearest future. So please, so many opportunities are coming up, and just identify them and be a part of them. About the emergency medicine interest group in Nigeria, what I would say for now is that we had already closed applications, because we found that so many people were applying who do not have any interest in emergency medicine. They were just applying just because, something opened up and something came up and everyone wants to be a part of it. But when we really probed further, we saw that people didn't really have any interest. So what I would say for now is that you should please send us an email. I will drop the official email for the interest group on the chat. Please just send us an email. If you're really, really interested in emergency medicine and you're in Nigeria, please just send us an email with our official email, and we'll definitely take it up from there and see how we can integrate you into the process for now. So I don't know. Let me just try and send that email as well. Yeah, I think I've answered the question.
Okay.
Thanks.
Okay, thank you very much. So maybe from the attendees, we can get a few questions as we wind up. You can feel free to maybe raise a hand or just type it in the chat.
If you're from Uganda, and I do know that there is an emergency medicine interest group in Uganda currently. I think that is in Mbarara University of Science and Technology, MOST. So, and the president is Jonathan Kajimu. That's for those in Uganda, but I think that interest group is limited to that medical school. But if you are thinking of establishing an emergency medicine interest group in Uganda in your own medical school, you should contact Mr. Jonathan Kajimu. That's an excellent person you should be in contact with. So, medical students from Uganda, Mr. Jonathan Kajimu is someone you should definitely find and contact. Try and find him on social media or somewhere. I think he's also in this, if you can indicate as well, because it's a really small community currently, so we almost all know each other, and you should definitely find them, get to know them, and we can really help you in building things in your own medical school and in your own country.
So maybe Dr. Wachira, you can give a closing remark. Anything else you might want to comment on? And then we'll also have a remark from Dr. Adebisi as we are winding up.
Thank you, Lilian, for really great moderation, by the way. And really, I think I would like to thank the organizers of this student summit. I think we need more of this, and we need these discussions on a regular basis where we actually are looking at the future of healthcare system, specifically from my end, the future of emergency care. So the students, at one point, you people will be the ones providing care to us when we get old. And to be honest, I don't want to be in a system where there's a professor who came to the emergency department, and he was adamant that he did not want to be treated by any of his students. And I was like, why? See, you taught them well. But for me, my main issue would be I would want to be treated by you people down the line, and the only way this would be possible is ensuring that you people have understood emergency care, learned emergency care, and developed the systems appropriate, so that when I need my emergency care, I know there's a system that will be developed, has been developed, and you all are part of the system. So kudos to all of you, and really look forward to working with all of you through different forums, whether through AFEM, through Emergency Medicine Kenya Foundation, through Adebisi, the Student Council, and I'd encourage all of you to join the Student Council, AFEM Student Council. As you can see, the leadership is quite strong there, Dr. Adebisi leading them all. This will help us also ensure, and the importance of it all. Remember, as organizations, your input is really valued. So from your input through the Emergency Medicine Care Foundation, through AFM, we can then develop the appropriate resources to support your work wherever you are at. But we need the input from the ground, and you're the people on the ground. So whatever support you need from our end, please feel free to reach out. We'll be more than happy to work with all of you.
Okay, thank you very much on that. Then Dr. Adebisi, and I'm also seeing to Dr. Adebisi, there's a question for you. Is the interest group in Nigeria open to other health students? I'm guessing that's people who are doing something else other than MD/CHB.
Okay, thank you for that question. I'm really sorry to disappoint you that currently it is just for medical students. In fact, we know I do acknowledge the fact that it should expand to involve and include medical and healthcare students in other aspects of training, but currently it's still just for medical, because we're still figuring out a lot it's new. It's just about a month old, so it's a lot is still being figured out. But we would definitely consider and put that into consideration, expanding to also include and involve healthcare students in other aspects of training. Thank you for that. My closing remark, I do hope I'm speaking to the medical students when I say that emergency medicine is an amazing specialty. It is, I can say it's the best specialty ever. And you will definitely be satisfied in emergency medicine. I can understand many medical students like emergency medicine and really appreciate the specialty, but they are bothered about whether it is enough. They say, okay, can I do emergency medicine and can I do this and, but you don't think about other specialties doing them and emergency medicine is enough. It is enough in itself. You don't need to combine it with internal medicine. You don't need to do it and a surgical specialty. Emergency medicine is a satisfying, amazing career option for you as a medical student. It is new and there are several opportunities. You would scale like this when you get into emergency medicine, opportunities in administration, leadership, in building, and there's a lot of work to be done. So if you're interested, I call on you to please come and join us as we build the African emergency medical system and also your own national emergency medical system. Come and be part of the work that we are doing. And I hope that in the nearest future, when we look back at what we have done all together, we can see that emergency medicine would have progressed to an enviable specialty in Africa. Thank you all.
Okay, thank you very much. Then, Dr. Wachira, I think you'll be the one best to tackle this. There's an issue on the chat about the AFEM membership. There's only room to join it as having a degree in MED or in MBCHB, not as a student. Maybe you can guide.
Yes, I've just tick as an MED, which tick as a student, MBCHB, or tick. It's something we can correct via email. I've quickly sent a message to the admin to adjust the form. So don't let that be the limitation. Just tick, and it doesn't really matter at this point. It's something we can clean up as we clean up the database. So don't worry about that. So tick MBCHB or whichever you want to tick there. And then we can always clarify this via email.
Okay. Thank you very much, everyone, for the great session we've had. I think we can reach Dr. Annet and Dr. Wachira via email or, yes, if there's any other issues, and Dr. Adebisi, I think they dropped their emails. And I hope we've all learned something great. And yes, thank you for attending the session. I'll now hand over to Okoth. I hope you're there.
Yeah, right.
Yes.
Wow. What a brilliant session that we have had. Thank you, Lilian, for the awesome moderation. Thank you so much to our panelists, Dr. Adebisi, Dr. Wachira, and even Dr. Annet. We appreciate your commitment. We appreciate your input into this. You guys have worked for long before this day, just to ensure you're ready for us. And on our end as healthcare students, we want to thank you and to make a commitment that whatever has been shared here we shall continually build upon it, so that wherever you guys have reached, we will not be building up. Thank you once again, Lilian. Ladies and gentlemen, I want to make a special recognition for Lilian because this is her very first moderation. She has done it perfectly. When I called her and asked her to do this, she was like, yes, I told her, oh, no, you can do this. Done it. So thank you so much, Kelly.
Thank you also, Okoth.
And to my colleagues in the organizing committee, we appreciate you as well. Thank you for your efforts. Thank you for believing in the cause. Thank you for believing in Africa. And I hope that we will continue to see the dreams that we have cherished come to fruition. Ladies and gentlemen, I want to wrap this for now and to invite you for the next session, which will begin at 2 p.m. Central Time. And I will look forward to seeing you then. Thank you so much. And I'll call it a session for now. Asanteni sana.
Bye, everyone.
Bye-bye.
Thank you, everyone, and bye.
Goodbye.